Hi, everyone. Thanks for joining our Birth Speaker Series this June 2024. We are so excited to have Sherri Gunn here with us. Sherri is a mom of 6 with a passion for helping families navigate breastfeeding and tethered oral tissues. She has been a registered nurse for over 22 years and a lactation consultant for 12. Side note, she's also currently getting her degree to be a nurse practitioner. Shout out. She loves to travel with her family, do yoga, and tend her fake farm. She and her business partner, Anne Tullis, have spent the last decade traveling and learning from the leading experts in the tongue-tied field. They opened Utah Breastfeeding and Tongue-Tie Center to be a place for families to get education and support. Sherri, we're so excited to have you.
Thank you so much. I'm happy to be here. So I guess I'll just go ahead and get started with my presentation and share my screen, and we'll just get the ball rolling.
Perfect.
Okay. Okay. So you can let me know if it is not working. But yes, as Kayla said, I am all about tongue ties. And so I'm happy to be sharing with you the knowledge and my experiences and things that how tongue ties actually affect daily life. And this is a birth series recording, so a lot of it is also about babies, but also babies grow up and babies become kids and adults. And so we're just going to talk about how things evolve and what they affect. So here's our agenda. What's a tongue tie? Feeding, breathing, and sleeping. Necessary for life, all 3 things. So um, she gave you a little bit of an introduction. So now here's a picture to go with what you heard. My biggest supporter and cheerleader is my husband. His name's Josh. I have 6 children ranging from 19 to 5. I do co-own Utah Breastfeeding and Tongue Tie Center, and it has a dream come true. I've been an RN for 22, IBCLC for 12. I also am a myofunctional therapist, which means I do therapy to have people help rehabilitate their tongue before and after tongue tie releases, or even if they don't have a tethered oral tissue, sometimes the tongue just needs some rehab like the rest of our body. I also am an ISS microcurrent neuro feedback practitioner. And like Kayla said, I'm also in my master's program. So basically all that rolls into is that I'm just really tired most of the time. So what is a tongue tie? And the medical terminology of it is ankylosing. And what that means is there's a malformation which restricts the range of motion of the tongue. And here are some pictures of tongue ties. And as you look at the different tongues on this page, it is very, very apparent. These are all very, very apparent that they're restricted. The interesting thing is that in my line of work, a lot of times I hear parents tell me that, oh, you know what? I asked if they were tongue-tied, and the doctor said, nope, they're not. And I said, well, did the doctor put fingers in your baby's mouth? And they say no, but they saw that the tongue could stick out past their lips. And that is one way to look at a selected range of motion of the tongue, the extension, but the tongue has to move a lot of other ways. And so like some of these are patients I've worked with, the cutie patootie in the middle with the blue gloves, that is my baby number 6. That's Brett. So I didn't realize that all my kids are tongue-tied. I didn't learn about tongue ties till baby number 5. And I didn't get anyone released as an infant until baby number 6. So, deliver that cute, sweet, perfect newborn, put him on my chest, and I put my finger in his mouth, and I started crying. And my husband's like, "What's the matter?" I was like, "He's tongue-tied." And then, sure enough, I looked. I mean, look at that little tip. It's right to the tip to the gum line. And so I'm going to share more about his story later, but this is the day that we got his tongue tie clipped with scissors at day 3 of life, and then we did a laser procedure at 6 weeks old. So I actually do know what my parents are going through and my patients are going through. on the mom side of things, having gone through it with my own child. And then I also got my own tongue tie released as an adult, as a 38-year-old. And I'll tell more about my story as we go on. But everybody, and this is the slide, right, has and needs a lingual frenum. What we look at is where it attaches on the bottom of the tongue and where it attaches to the floor of the mouth. So there are some people who I've looked at their tongue and I'm like, wow, they're so tied. But it's elastic. They have great range of motion. They don't have symptoms of a tongue tie. And so, we don't do anything about it. There's no need. There are other people where they have a tongue that doesn't look restricted hardly at all, and their function is so poor. They can't do all the things that their tongue needs to do. So it's not cut and dry in this tongue-tied world. It's really, really hard. A lot of times when we start to talk about tongue ties and about some of the symptoms, parents just run out and get the tongue tie clipped because they're like, oh, see, know the problem, let's get it fixed. It'll make everything go away. And unfortunately, that's just not how it works. So it takes a little bit more education and time and development and sometimes strength to have symptoms resolve and have that homeostasis that we're all looking for in our life. So for the first thing we're going to talk about is feeding. And because I'm in my master's program, you guys are going to see a lot of educational videos. And if you've been one of my patients before, you've seen a couple of these videos because they're my favorite. But it does such a good job. And I'm a visual learner. I need to see what's going on inside the mouth with the tongue so that I can process what is happening when we start to see things that are, unusual. So this first one is breastfeeding. And I want you to pay attention to the tongue. This is, and I can't say their name, Dr. Farquhar, ENT. I love his slides and his animations. But look how far that nipple is in this baby's throat, like legit swallowed down their throat, right? The tongue stays in contact with the nipple the whole feeding. It doesn't come away, it doesn't smack, it doesn't lose suction, and it's a very smooth, rhythmic movement.
In order for effective breastfeeding to occur, a good latch is required between the infant mouth and the breast. An effective latch requires a few things from the infant. The mouth is widely open with lips that are flared or curled out. The tongue is extended over the gum and under the nipple. The nipple needs to be fully inserted into the mouth, including some or all of the areola. If any of these factors are missing, breastfeeding may become ineffective. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling and gas pains. A normal infant tongue has good mobility. Tongue tie is when the tongue is stuck to the floor of the mouth, preventing adequate mobility, which leads to an ineffective latch. The tongue tie may also be hidden under the mucosal lining, a condition called posterior tongue tie. With tongue tie, the tongue tip does not extend over the gum, causing the newborn's gum to chew on the nipple during feeding. Also, the up-down motion of the tongue is hindered, preventing an adequate suck, resulting in decreased milk production. A surgical procedure called tongue tie release can easily correct this cause of ineffective breastfeeding. Upper lip tie is when the newborn's upper lip does not curl up or flare out enough, resulting in loss of suction and the nipple to be incompletely engaged within the mouth. A surgical procedure called upper lip tie release can easily correct this cause of ineffective breastfeeding.
So did you see all of that air that is in there when the baby was swallowing with the tongue coming completely away from the nipple? So a lot of times when he talks about noisy suckling, gas pains, sometimes the tongue tie gets missed because the mom's body is so good at feeding the baby. It's really hard for a mom when she feels like she knows. Moms know when something's not right, especially when it is regard to feeding, because she is staring at this baby's face and her boobs all day long. Or a bottle, like if the bottle's not going well and baby's gassy and smacking and leaking, and it takes an hour to get a bottle, an ounce into the baby, moms know something's wrong. So it is very frustrating. And this is where it's really hard when a pediatrician or, somebody else is like, well, your baby's gaining weight. Your baby's doing just fine. And sometimes it's not fine. And we have to kind of dig a little deeper and see, okay, what's going on? Because moms that can just fire hose it into their baby's not pulling milk. And a lot of times when I see a baby that's 3 months old or 4 months old, what's happened is the babies, we call them just like they ride the waves, right? They ride that letdown. And when they're newborn and little, that letdown's all they need when we have an oversupply or a fast flow. And then when they get bigger at about 6 months, they need to be able to fully extract milk from mom to be able to get enough for what they need to grow. So we see a little bit of a weight decline. And sometimes moms panic at that moment, or then the pediatrician's like, oh, maybe you should go see somebody about why baby's struggling. And it's common for me to be the third or fourth IBCLC they've seen. And it's not for, again, not any reason that the pediatrician didn't look or the other IBCLCs didn't look. It's just that there's not a lot of training on this. This is kind of a new field. It's not a new condition. It's been around, it's like the very first medical tool that was created for this king, the 1700s, was the tongue tie spoon that holds up, and then they could clip the tongue tie underneath. So it has been around. But babies back then, they didn't make it if they couldn't eat, and they passed away because there weren't bottles or other ways to feed babies. And so they didn't pass on genes that had tethered oral tissues. Not always, but anyway, I get beside myself. So more feeding, right? So now we've moved on from breastfeeding and bottle feeding to chewing and swallowing. Now, a lot of people say, well, if they're not breastfeeding, why would you release the tongue tie? Why put a baby through that procedure? Why make the parents' lives miserable while we have to do the aftercare stretches if they're not going to breastfeed? I hear a lot of moms say, I just ended up pumping and bottle feeding, because of XYZ. So I wish I wouldn't have done it because I'm not breastfeeding. But it's not the case. It's not just about breasts. It's not just about nipple feeding. It really isn't. So everyone needs good tongue function to swallow. We have to cup the bolus, be able to move the food around our teeth, put our tongue to the roof of our mouth and swallow with minimal air. And so this is going to show you about the 4 different stages of swallowing. Watch the tongue. See how it has to move. I explain it to my little kiddos when I'm doing my functional therapy, like an octopus tentacle. You know how it can move in different ways and shapes and form different things. So the tongue has to extend, it has to cup, it has to elevate, it has to be able to push things, it has to be able to seal and suction to the roof of the mouth. It's not just for nipple feeding. So here's the swallow.
With a normal swallow, food and liquids move from the mouth into the esophagus directed by a precise sequence of coordinated muscle movements. In order to adequately describe the biomechanics and bolus movement during swallow, the 4-stage model was developed. Let's slow down the animation in order to more clearly appreciate what happens during normal swallow. The 4 stages are as follows: oral preparatory stage, oral transit stage, pharyngeal stage, esophageal stage. During the oral preparatory stage, food is kept in the front part of the mouth where it is moistened with saliva and chewed into a softer consistency. Once the food bolus has been processed by the mouth, the oral transit stage begins with the tongue raising up against the hard palate while the back of the tongue drops to allow the bolus to move into the back of the mouth. Simultaneously, the soft palate raises up against the back while closing off the passageway into the nose, preventing any food or liquids from regurgitating back up into the nose. The pharyngeal stage is a rapid sequential activity during which the bolus is propelled into the esophagus. The larynx elevates while the epiglottis flips down, protecting the airway. Not clearly shown are the pharyngeal muscles which contract, squeezing the bolus downward. The cricopharyngeus muscle, or upper esophageal sphincter, relaxes and opens to allow food and liquids to pass into the esophagus. Once the bolus passes the cricopharyngeus muscle, the esophageal stage begins. The cricopharyngeus muscle closes back up to prevent any regurgitation back up into the throat. The esophageal muscles continue to propel the bolus into the stomach by a coordinated muscle contraction and relaxation known as peristalsis. The mouth and throat resets to prepare for the next swallowing event. Should there be any deficits or coordination problems at any point during the 4 stages of normal swallow, choking, aspiration, nasal regurgitation, or even the complete inability to swallow may occur.
So there are other problems that happen with swallowing that can cause issues. It's not just the tongue. Any part of that swallowing phases, you can have issues with. But the tongue is a major player, right? The tongue has to be able to gather the food from all over the mouth and put it into the middle of the tongue. I always talk to my kids about how it's like a dump truck and the tongue goes to the roof of the mouth and, starts that food going down in the right direction. I was 38 when I had my tongue tie released, and I didn't realize that I had been swallowing wrong my whole life. And so I don't have a video of my first swallow, but it probably looks pretty much like my friend here, Janine. So I have so many stories that I could share of different clients that I've worked with that they're having their tongue tie releases change their life completely. And I'm one of those patients. It changed my life. It changed a lot of my issues with neck tension and headaches and air and sleep issues that I had. But I remember my first swallowing the correct way without a tethered tongue. And I remember actually being mad because I was like, wow, this is the way my tongue was supposed to swallow my whole life. And I haven't been swallowing that way. And I was like jealous of everybody else who has like a normal tongue and swallows the right way, because I had to work so hard to retrain my tongue doing myofunctional therapy. And I have patients hold like a little orthodontic elastic on the tip of their tongue. So they hold their tongue to the roof of their mouth and then like they swallow water that way, or we put a cracker in their mouth and they have to hold that rubber band while they swallow the cracker down. It's a lot of work to retrain a tongue who's been swallowing wrong their whole life. So here's Janine. She is a registered nurse herself. She's a researcher. She's brilliant. And like it says on the slide, like many of our clients, she comes self-diagnosed. She knew there was a problem. She was searching for an answer. She saw something. She read something. She's like, I think that's it. So she's allowed me to share this video of her first swallow. So we had just released her tongue tie at our office, and I knew she was going to have a drastic change because her tongue was so tight and so tethered. So here's Janine. No, I know.
Okay, should I do it?
Yeah, just take a drink.
What the heck?
She could stick her tongue out so far. She was so happy. She could open her jaw so wide. She was so happy.
Oh my gosh. What? Okay, so when should I eat now?
No, I know. So yeah, just take a drink. Anyway, so that's Janine, and that's her first swallow. So feeding is huge, right? From birth, we have to eat. People who choke on water, some symptoms are like, I bite my tongue all the time. I have a scalloped edge of my tongue because your tongue's staying on the floor of your mouth. There are lots of symptoms that go along with being tethered and being stuck to the floor of your mouth. Jaw tightness and tension and exhaustion from speaking. People are like, I get so tired talking. Well, it's because your jaw is attached to your tongue and it's trying to work when it shouldn't be. Your tongue is designed to work, swallowing, talking, all those things all day long. That's what it's designed to do. Your jaw, not so much. And so that is one of the things that we deal with tongue ties. So the next is breathing. And I love how we just have this huge functional medicine health movement going on right now. And I love that breathing and nasal breathing is a big media hit right now. It's in the news all over the place. So it's helpful for parents and providers to be realizing that, it affects the whole body, and mouth breathing is something that is detrimental to our health, actually. So let's talk about that. Nasal breathing versus mouth breathing. So nasal breathing humidifies and warms the air, where mouth breathing dries out your mouth and your mucous membranes that are supposed to stay moist. Nasal breathing filters pathogens from entering the body, where mouth breathing actually creates gum inflammation. Nasal breathing helps keep nasal passages clear, whereas when you mouth breathe, we're not moving the mucus through with the air, so it actually increases congestion. When I had my tongue tie released, before that, I remember in the morning, I would just blow my nose so much because it had been congested all night long. I had been mouth breathing all night long, and I had no idea. I just, attributed it to allergies or whatever. And so I don't do that anymore because I nasal breathe and am able to clear that. It's amazing. The other thing that we're going to talk about is growth and development. So when we nasal breathe, that is the correct and normal growth and development of oral and facial structures. Whereas mouth breathing actually inhibits normal growth and development, which is why it's so important, and we actually change the trajectory of a child's life if we get in early and have that early intervention of tongue tie release. Truly. My son's face would look different, and I can guarantee you that, if I would have left his tongue tied. So this is another little, I told you guys I love visuals. So because we can't see what's going on inside the nose, here is another little thing that kind of explains the difference. And I love this imagery because look at that tongue. It is sectioned to the roof of the mouth. The teeth are gently closed. The lips are sealed. This is good posture. This is good lip posture. This is what an infant needs. This is what an 80-year-old needs. And I cannot tell you how surprised everyone is when I start to teach about this. And they go, wait, your tongue's supposed to be on the roof of your mouth? I was like, yeah, I know. Mind-blowing, isn't it? It's only mind-blowing for the people whose tongues are on the floor of their mouth. Everybody else is like, oh yeah, that's where it's supposed to be.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, Your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
So I love that because it talks about so much, right? And it helps parents and individuals visually see why the tongue suction to the roof of the mouth, the whole tongue, not just the front of it, the back of it, needs to happen for the growth and development. So here's the side profile view of a mouth breather versus a nose breather. So when I was in my myofunctional therapy course, everyone was like, "Oh, Sherri, you're tongue-tied." And I was like, "No, I'm not. I don't have any speech or feeding issues." And they're like, "Well, you sleep with your mouth open." And I was like, "Oh, I sleep with my mouth open." And they're like, "Well, you're the mouth breather profile." And I was like, "I am the mouth breather profile." So 100%, I check all the boxes. Tired eyes, restless sleep and snoring, set back jaw, leaning forward, poor head posture, narrow palate, lower oxygenation, higher, well, okay, I didn't have the higher blood pressure, but stress activation, check, 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 check. Now, again, if this is generalized, right? So you can have a little both, and I've seen it happen. You can be a mouth breather and have alert eyes and be a deep sleeper. I've seen it happen before. It's not common, but this isn't like a hard fast for everyone. But generally speaking, if the tongue is on the roof of the mouth and you're a nose breather, you are going to have better eyes, jaw and cheekbone definition, deeper sleep, higher CO2, parasympathetic relaxation because you're nose breathing. What do you hear when people are like anxious? Take a deep breath through your nose. What does that do? It calms down the nervous system. We get that wide palate, spine support. One of the lecturers I've heard, she always says, the tongue is the rudder for the spine. And it is, it really is. So if we have good tongue posture, we usually have good, not always, but usually we have good spine posture. So that is why, and this isn't just about breastfeeding. This is about facial development and growth. And when does growth happen the most and the quickest? When you're little, when you're a little kid, like that is when we can have the most impact with growth and development. Okay, our last section is sleeping. Again, this necessary for life. Feeding, breathing, sleeping, all necessary for living. Okay, so just again, I'm in school. I'm so sorry, but you are guys getting all this education thrown at you in 45 minutes. So now we're going to talk about the neuroscience and the stages of sleep.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss the stages of sleep. Sleep stages are defined based on the measurement of electrical activity in the brain using an electroencephalogram, or EEG. An EEG represents fluctuations in brain electrical activity and voltage as a waveform of variable frequency and amplitude. The American Academy of Sleep Medicine classifies sleep as consisting of 4 stages. The first 2 stages involve light sleep. When someone begins to fall asleep, they enter stage 1, during which an EEG records low amplitude waves of mixed but mostly high frequencies. Next, the person enters stage 2 sleep. This is characterized by the presence of phenomena on an EEG known as sleep spindles and K complexes. Sleep spindles are trains of high-frequency waves. The K complex involves a biphasic wave that stands out from the rest of the EEG. Stage 3 sleep is also known as slow-wave sleep or deep sleep. In Stage 3, delta waves, which are low-frequency, high-amplitude waves, make up at least 20% of brain activity. Stage 3 sleep is thought to be especially important to overall restfulness. Next, the sleeper passes rapidly back through Stage 2 and Stage 1 before entering rapid eye movement or REM sleep. In REM sleep, EEG activity resembles what's seen in Stage 1 or restful waking. During REM sleep, the muscles are completely relaxed and limp, but the eyes are moving rapidly. This is the time of sleep when our most vivid dreams are likely to occur. After REM sleep, the person will sometimes awaken briefly, but then will move through the sleep stages again in order. Most people will repeat this cycle 4 to 5 times a night, with each cycle lasting about 90 to 110 minutes.
Okay. So here, welcome to my family. Here are pictures of me asleep. This little guy on the left right here, that's my Brett, and that was him this morning. He decided to put on Daddy's pants and fell asleep on the floor in the pillows that are on the, were on my floor that day, this morning, 12 hours ago, 10 hours ago. So this is what I need people to understand as well, is that even if we release the tongue as an infant and we are putting them on that trajectory for a better growth and development and oral function, sometimes it doesn't kick in yet, and this is why. So that little teeny cutie patootie on my other slide that had the blue gloves, this is Brett. He's currently 5 years old today. This is his mouth today. And look, he's a mouth breather. And everyone's going to be like, wait, what? You just said he released his tongue tie twice. And I'm a myofunctional therapist. I did all his exercises. I did all his stretches. I have done everything. But Brett has a super high vaulted palate, cathedral palate, bubble palate. I don't care what you want to call it. So high. So right now he's currently in a palate expander at 5, so that I can expand his palate and get space for his tongue and get him developing the way he would have had he had his tongue on the roof of his mouth in utero. Okay. It's taken me 5 years to get to this point. So it's not like, again, clipping the tongue tight. Sometimes it does fix it. And sometimes I have seen kids with tongue ties that actually have wide palates, and I don't know how it happens, but I've seen it. Wasn't the case for myself nor my son. So when we see people that are frustrated that the tongue tie didn't work, it didn't fix all the problems, it's a start. It's a piece of the puzzle. It gets us in the way we need to go. But seeing an airway dentist, a functional airway dentist, having them keep an eye on your kid, knowing that if I release this baby's tongue tie, I am now on that airway train. I need to be looking for ways and things that I can do to help them nasal breathe, to help their palate, give them hard things to chew, give them, not such processed foods, which again, I'm a mom of 6. Hello, I'm talking like I totally give my kids processed food, but let's throw in some hard stuff, carrots, raw carrots, the artisan bread with that big crunchy where they're actually chewing a lot of times. So great. So great. So the middle picture is myself with my daughter, my second daughter. This is 16, almost 17 years ago. And of course, as a new mom, you are exhausted. And this picture my husband took of me, and I am sleeping with my mouth open. Surprise! I mean, no one's surprised. My mouth is open. And my tongue was tied, so I didn't know that I guess I wasn't conscious that I was a mouth breather back then. But this is me sleeping with that same little Brett a couple of years ago. And he and I are snuggling, and I'm sleeping with my mouth closed. And my husband showed me that picture, and I legit started crying because I have worked so hard to keep my mouth closed. It worked really hard. Okay, so we're still talking about sleep. So when I started in the tongue-tied world and we were doing stuff, I was going to conference. I had my husband. I was like, I need you to take a picture or a video of all the kids sleeping tonight. I need to know what's going on with their mouths. And this is my same little second daughter that I was snuggling with. See if you can hear her. You hear that clicking? So when you do not get into the deep sleep, a lot of times mouth breathers don't get deep sleep. If you wake up feeling tired and exhausted, I had ample reasons to excuse away my tiredness. I worked as a night shift nurse. I had kids, lots of them. So I haven't slept in, my oldest is 19 years. I've always, some kids awaken with vomit or diaper, bad dream. So, but I didn't know what it was like to wake up feeling rested. My husband always joked around, you can sleep for 12 hours and wake up feeling tired. It's because I was not getting deep sleep. In order to get really good deep sleep, you need to breathe through your nose. And I love this, what this little clip says about.
If you're going through proper sleep cycles and you have good circadian rhythm, each one plays a substantial role in maintaining your health. You usually start your cycle in stage 1. Stage 1 is a full cycle and it takes about 90 to 110 minutes. And ideally, you need 4 to 6 cycles. So that's why generally you want you to sleep 7 to 9 hours so you can go through all those cycles. Between 10 and 2 a.m., the body goes through a dynamic process of physical repair. Between 2 and 6 a.m. is when the body goes through the psychological repair. Disrupted sleep patterns can cause the cortisol to elevate and the blood pressure to elevate, and it negatively affects the regenerative process that you should be getting right before we're going to wake up.
Really
That's when we really repair and restore.
Let's look at all these
So
handy
sleep
dandy
is
devices
really
to help us
important.
not mouth breathe. I mean, these I all got from Amazon. You can spend $20 on these packages. And I actually do tape my mouth to sleep because even though my tongue is on the roof of my mouth, because back in the 90s, my good old orthodontist pulled so many teeth and pushed my jaw back with elastics, my jaw always wants to relax and open, even if I have my tongue on the roof of my mouth. So mouth taping is a thing, and it does help you nasal breathe. And you can buy all these things that are kind of sometimes absolutely ridiculous, like the chin strap and the top. But this is how important that nasal breathing is, and having your tongue suction on the roof of your mouth. If your tongue is doing its job, your mouth should be closed, unless you need some help because you got your tongue tied at least when you're 38. But and the interesting thing is that I remember I didn't have many dreams as a kid. And in that myofunctional therapy training, they said, Sherri, tape your mouth shut tonight. And I was like, what? Tape? What are you talking about? Tape my mouth shut? And I'm a claustrophobic person. So the last thing in the world I ever want to do is tape my mouth shut. But I was like, okay. And I tried it and I had a dream that night. Not only did I have a dream, but I woke up feeling rested because I actually got into a deep sleep. It was amazing. And so then I did my myofunctional therapy after that, got my tongue tie released. I am sleeping so much better than I ever have in my whole life. And so, the last little thing I have to leave you with is, you too can look like me. Ka-chow. So, conclusion is, full range of motion and function of the tongue is essential to all aspects of daily living. Feeding, breathing, sleeping. Oral restrictions do not only matter to breastfeeding babies. And if anyone has problems or questions or concerns, or you're like, wow, that was a lot of information, I have a ton of questions specific to me or my kids or what I'm dealing with, I'd love to chat about it. We do tongue tie evaluations. We have speech therapists, myofunctional therapists. We do tongue tie releases at our space. We are in this world and we're in it to help you. So give us a call, look us up on Instagram, shoot us a message, Facebook, email, go to our website. We just want to help. So, and that is the end of my presentation.